we go on to our next speaker, Dr. Avinash, because I think he needs to get back to his theater. I do hope he stays for his 45 minutes. He is going to be dwelling on varied clinical presentations of ocular toxoplasmosis. Let's hear from him.
Right. At the outset, I'd like to thank Dr. Chitra Ramurthy for giving me an opportunity to talk on clinical manifestation on ocular toxoplasmosis. So I would be presenting on 9 different points, which would help the postgraduates to understand toxoplasmosis better. So why toxoplasmosis is important? Because it's the commonest cause of infectious posterior uveitis. Though we know 90% of the uveitis are non-infectious and 10% are infectious, in those 10%, the commonest cause is toxoplasmosis. So in our lifetime, when we have a practice, there's no way in which we can escape toxoplasmosis in any form. So with that positive note, let's move on to the second point. Is it easy to make a diagnosis of toxoplasma retinitis? Yes, it is. So, and the point which I want to emphasize is pattern recognition. Pattern recognition is very important to make a diagnosis of toxoplasmosis. So we are all aware of the fact there is a hyperpigmented scar, like the one you see on the right-hand side of the screen. There's a hyperpigmented scar, and adjacent to it, there is an activity or a necrotizing retinitis. This is something which is so easy to diagnose, and this pattern can be imprinted in anyone's mind to make a clear-cut diagnosis. Having said, not all cases of toxoplasmosis present in adjacent to a hyperpigmented scar. Sometimes you can get an unifocal necrotizing retinitis like the one what you see on the left-hand side. And many times these retinitis patches, what we get to see, they are just about the size of the disc or a little bit smaller than the size of the disc. So that's how one can make a diagnosis of toxoplasma retinitis. It's a unifocal necrotizing retinitis which may or may not be adjacent to the scar. So pattern recognition is very important to make a diagnosis. So can anterior segment findings help us to make a diagnosis of toxoplasma retinitis? Most of the times not, but sometimes it does. Mainly it comes from the fact that some of these keratic prespirates which can be seen in an acute setting can be pigmented in case of toxoplasmosis. And very rarely, they can even have a raised intraocular pressure. So the corroboration could be like if one gets to see a necrotizing retinitis, a unifocal necrotizing retinitis, and the pigmented keratic prespirates anteriorly and the raised intraocular pressure, if we have a logical thought process aligned to it and corroborate all three of them, then it might make sense. So that's how an anterior segment finding can help us make a diagnosis of toxoplasma retinitis. So having spoken about the typical manifestations of, there's a recurrence or activation next to a scar. So there are also known as atypical or rare manifestation of toxoplasma retinitis. So let's look at some of them. And one rare manifestation is the juxtapapillary retinochoroiditis. And the significance of juxtapapillary retinochoroiditis is it can lead to an enormous amount of central visual loss and would always involve the central nervous system in cases, especially if they're immunocompromised. And they can have extensive visual field defects because they're very close to the optic nerve head. And one thing which is important is unlike retinitis which occurs or toxoplasma retinitis which occurs away from the disc, these do not leave a footprint. What I mean by footprint is when a toxoplasma retinitis resolves, it leaves a hyperpigmented scar, but the ones which are on the disc and close to the disc rarely leave a footprint. That's how different it could be. So having spoken about it, the next varied manifestations of toxoplasmosis which one would get to see is the ones which occur in immunocompromised. Here, I would like to make a point that toxoplasmosis in HIV is not an AIDS-defining disease. So now, how different it is in immunocompromised patients over immunocompetent. In immunocompetent, like what I told you, I don't mind repeating again, unifocal necrotizing retinitis, and there you can see it has a very vertical spread. From the retina, it goes to the choroid. Whereas in immunocompromised apart from the retina going to the choroid, it also has an extensive horizontal spread, so which would not be seen in immunocompetent people. So in immunocompromised, it has both vertical and horizontal spread, unlike in immunocompetent people. So the next point is sometimes in an immunocompromised patients, they can be multifocal, and like what I told you, it's extensive, and they are usually non-pigmented. Having said about the necrotizing retinitis in immunocompromised, the next point which comes to our mind is how can we differentiate it from a cytomegalovirus retinitis, because even that can manifest as a necrotizing retinitis. Let me share two important clinical points by which the diagnosis can be made right away on clinical evaluations. In Toxoplasma retinitis, the vitritis is more prominent than in cytomegalovirus retinitis, and number two is lack of intraretinal hemorrhages. So necrotizing retinitis in cytomegalovirus is usually associated with hemorrhages, but in toxoplasmosis, it does not. And these are the comparative images one would be able to clearly understand how to differentiate necrotizing retinitis from these two organisms in immunocompromised patients. So very rarely, toxoplasmosis can also present as acute retinal necrosis. Having said that, acute retinal necrosis is a morphological diagnosis. It doesn't mean of one particular etiology, and especially when we have a recalcitrant ARN, consider toxoplasmosis as a possible etiology. Now, the next point most of the postgraduates would like to know or they keep talking about is headlight in the fog in toxoplasmosis. So headlight in the fog is rare manifestation of toxoplasmosis. It's not that common as one would like to see. And it is not pathognomonic of toxoplasmosis. Here, I'd just like to share, the other day, I got a patient who had been referred as a headlight in fog, but the patient did not get well with anti-toxoplasma treatment. The patient had a dehemoglobinized blood with overlying resolving vitreous hemorrhage. So that's how it was confused with headlight in fog-like appearance. Though the appearance was headlight in fog, so it doesn't mean that all headlight in fog means toxoplasmosis. So let's move on to the sixth point. And there are other clinical changes adjacent changes which happen in the necrotizing retinitis of toxoplasmosis. One among them is vasculitis. So there are three types of vasculitis which can be associated with toxoplasma retinitis. The first being Chiarilis. So Chiarilis vasculitis is intravascular accumulation of these deposits. And the additional point which I would like to share is these Chiarilis vasculitis may not start simultaneously with Toxoplasma retinitis. The retinitis would be the first to start. The Chiarilis might start a little bit later. And the most important point which I would like to say here is the retinitis would resolve, but the Chiarilis would take a longer time for it to resolve. So Chiarilis would resolve about maybe a month, or there are some indications we have seen even 3 to 4 months after the resolution of retinitis, but not in toxoplasmosis. So persistence of Chiarilis is not an indication for treatment after resolution of retinitis. So we have to make this very clear if treatment is considered in the management for treatment of toxoplasmosis associated with Chiarilis. The second is skip vasculitis, which Sudarshan had mentioned on sarcoidosis. So skip vasculitis can also occur in toxoplasmosis, but nothing to worry about. They just disappear with the treatment, and they don't have any consequences with toxoplasmosis. The third is the confluent vasculitis. So confluent vasculitis has a consequence. The consequence is depending on which vessel it is involved. Sometimes it can lead on to occlusive vasculitis, like the one which you can see here. So we have adjacent hemorrhages which can happen. So having spoken about the 6 points, the seventh important point is there is always this confusion when people talk about it, whether it's chorioretinitis or retinochoroiditis. So let me share with you a simple OCT which can depict how toxoplasmosis starts. It always starts, it's a retinitis to begin with. And once it begins as a retina, and then it moves on to the choroid. So it is the retinochoroiditis, and I would defer to call it chorioretinitis, because chorioretinitis means starts from the choroid and goes to the retina. So toxoplasmosis, it's a retinochoroiditis.
1 minute left.
So what are the complications seen with toxoplasma retinitis? Let me mention about the 4 macular complications. macular hole, like the one we can see here, not very common, rare. Vascularized epiretinal membrane, the one which you can see here. And in this patient also, we can very beautifully see the posterior hypopyon in this patient. And third is a vitreomacular traction. And fourth is the choroidal neovascular membrane. This is a common manifestation in macular complication of toxoplasmosis, which can be seen both in active and as a late stage complication after inactivation. So vascular occlusion, like what you can see, is another complication. Chorioretinal anastomosis, because the retina and the choroid can, because of the infection and the necrosis, the vessels can get close to each other and form a chorioretinal anastomosis. And sometimes there can be a traction band, which can lead to a tractional retinal detachment, or the traction is too much, can create a break and can cause a combined detachment. The last point here I want to emphasize is in classical congenital bilateral punched out macular scar involvement, it usually represents, what does it tell us is the infection would have occurred in the third trimester, because if it had to happen in the first or second, or especially in the first, the abortion or chance of miscarriage would be pretty high. So those are the 9 important points which I would like to emphasize, and thank you for your patience listening.
Thank you very much, Dr. Avinash. All your 9 points have got really imprinted in our minds. But just some basic things like, I suppose, if it is a bilateral presentation, we could think more of a congenital toxo, and if it is also a centrally located lesion, then it's more central congenital than acquired, I suppose. But what about when the elderly people, when their cell-mediated immunity is less? In those cases, would you search for a congenital old scar, or would you accept it as an acquired disease?
So it's very hard to say whether it's a congenital or acquired. So sometimes if the scar is evident, then the diagnosis becomes obvious. But again, it does not goes on to say that if the infection had occurred sometime in the lifetime, not in the congenital and the third trimester. So it's very hard, because unless and until it is somewhere, it is in the posterior pole and it's a deep punched out scar, then the diagnosis of bilaterality, then the diagnosis becomes very obvious. Otherwise, it's very hard to find. So the patient, because it can resolve spontaneously in 4 to 5 months, and the patient may not be asymptomatic also.
Srinivas?
Avinash sir, thank you. Wonderful presentation. 9 commandments. I think most of the postgraduate.
I fell short of one.
We'll make it as 9 commandments, Dr. Avinash. You are definitely a different person, sir. So we'll make it 9 commandments. Sir, one question which most of us would like to know. In case of recurrent toxoplasmosis, say there is another lesion which is adjacent to the scar, and then we don't have FFA in all the medical colleges. Still, it is the thing where we need to know whether it's a reactivated scar. So what are the clinical signs which the postgraduate need to look at? So when the vitreous is silent, when we do a 90-day examination, few cells, vitreous cells over the lesion, will it give a clue that it's a reactivated scar? Because not all the time the lesion looks active. In what to do in such confusions when we don't have the modern equipments?
No, you don't require a modern instrument to make a diagnosis of reactivation. In the color itself, the color is, you have the white necrosis, right? So when it is healed, it is hyperpigmented. When it is activated, it is white necrosis. So whenever you see something white adjacent to a scar, then it is reactivation. Having said that, there is also a possibility that it could also be a very subtle choroidal neovascular membrane adjacent to a scar, especially if it is associated with a subretinal hemorrhage. That's where it becomes important to differentiate whether it is it's a reactivation of infection or it is a choroidal neovascular membrane formation. But the whiteness gives it away.
So just because sometimes we see the scars which are not pigmented, which are not scarred, but they still look whitish. And when you do an FAF in those cases, we still do see hypoautofluorescence. There is no activation of these lesions. So that's where is the confusion, which our postgraduates, most of them would like to say, sir, we need to do an FAF in these cases. So how really are these? Was my first question. And second question, indications of intravitreal clindamycin in cases of treating ocular toxoplasmosis.
Okay, so the first is I don't routinely do fluorescein angiogram to make a diagnosis of active toxoplasmosis. So it is basically on clinical evaluation which happens before that. So if it's a very small, say less than a disc diameter lesion, to pick up for cells over the lesion, so you have to stick a lens on the cornea, and then you should go pull the joystick back and look at the cells. But we can very well see it on the OCT to see for activity. Having said that, fluorescein angiogram, what are the fluorescein characteristics? If it's an activist, it starts with an intense hypofluorescence because of the blocked nature of the inflammatory exudate which is there. So after the initial hypofluorescence, it creates a perilesional hyperfluorescence. So that's a very characteristic of any retinitis which can happen. So especially in toxoplasmosis. In fact, even soft exudates will appear like this when you image a soft exudate. So moving on to the second question, what would be the indication of clindamycin intravitreal? So intravitreal clindamycin either can be used as a monotherapy or as an adjuvant therapy, but never as a monotherapy in a patient who has a systemic problem and also who has IgM positivity. So let me have the clarity on it. And never it is one injection. So I will give you the other clarity on it. So the indication would be any patient who has a lesion which is very close to the disc or a macula, or immunocompromised, or in the pregnant state. These are the 4 indications right away we can think about intravitreal therapy as an adjuvant modality of treatment.
Thank you, sir.
Thank you. Thank you very much, Dr. Avinash. Oh, Dr. Vaishali has a question. Yes,
Can I
Dr.
make a quick comment?
Yes.
In addition to what Avinash has told beautifully for the postgrads and the students, look at the margins. The scars will have a very distinct, well-defined margins between the healthy retina and the scar. Whereas the satellite lesion, which we are talking about, besides being white, what Avinash said, could have a kind of a fluffy border. So you will not have a distinct edge, and that might give you a clue that what you are dealing with is active.
Dr.
Vishwas?
Can I make a comment?
Yes, yes,
It's very important to distinguish and toxoplasmic retinochoroiditis and choroiditis. And you should see that the blood vessels going over here in a case of choroiditis. An active toxoplasmic retinochoroiditis, you won't see the blood vessels are going over it. And if you are doubt, do not give posterior subtenon or intravitreal dexamethasone implant. It will become devastating affair. And in case of immunocompromised patients, ELISA test may not be really hold that much importance. You might have to do PCR for toxoplasma DNA to find out from the intraocular fluid.
Thank you. Thank you, Doctor. Thank you, Dr. Avinash, for your
Thank you so much.
commandments. Yes, we'll remember that. Thank you very much. We shall now go on to our next speaker.